So hi again. This section of TIPA's clips about dementia and developmental disabilities is going to be broken down into 4 chapters, and these are the 4 sections that we're going to look at. So chapter 1 is going to be talking about we as care partners needing to take a time out. What does that mean? How are we going to do that when it comes to looking at dementia and developmental disabilities? Chapter 2 is going to be devoted to a review of the four types of dementia that tend to affect the DD population. I'm also going to give you some notes here that they're in this section. There were some technical difficulties, so I'll be popping in to let you know what I think TIPA was trying to say in that section. Chapter 3 is going to be a Q&A session with the people who are participating in the webinar. So you'll hear about 3 or 4 different topics that we bring up during that section. And then the last section is going to be, well, what should we do next? It also includes a little bit of role play around job coaching and working with someone with developmental disabilities that I think you'll find kind of interesting. Okay, I'll see you in a little bit.
What we're going to be doing today, I assume most folks know since you signed up, is talking about dementia in combination with developmental disabilities, intellectual disabilities, or whichever term at this point in time your region or area or part of the world uses to describe people whose abilities were altered from what one would have thought they would have had at birth or within the first 3 up to, in some cases, 5-6 years. But they are something that somebody's been living with their whole life. Whatever they have, and it's a little different than what most people have. But that doesn't mean that they haven't developed normally for them. But it turns out that there were some changes early on, either genetically or at the time of birth or pre-birth or after birth within the first few years of life that altered their life. They have been trying and successfully or somewhat successfully managing their life for their life until suddenly or slowly, this thing called dementia also impacts them. And so today's session is really looking at this element, dementia, the great big umbrella of dementia, as it impacts people who are living with developmental or intellectual disabilities. So yes, there are issues, but now we got new stuff going on. So one of the most important signals I'm going to give you, and if everybody wants to go ahead and practice this in real life, do this signal, and it means time out, is when you're talking about someone who's had a lifelong pattern that's a little different. What we want to take time out for is to notice something's changing, and the something changing isn't consistent with them. Historically, we frequently do a timeout and then say, oh, we need a behavior plan. We need a modification here to get them back in line, to put them back in the box that they've been living in. But the timeout, when we are looking at people who are indeed living their life and they've lived it up to a certain point, and then we're starting to notice some shifts, is to call a timeout on ourselves. And the timeout is to get us to look, does this seem like it's consistent with them, or does this seem like something else is going on here? And the things that we tend to look at are environmental factors, interaction factors, and then the person factor. But we tend to see it as the person has behaviors. And the behaviors are what we noticed, and so we either want to change how they interact or the environment. And this is that timeout where we need to go, well, it could be that, yeah, their behavior is changing, but the reason their behavior is changing is they have something new going on here. And even though we were hoping it was a medical condition and that's all it was, maybe the something that's going on is actually changing them because it's destroying their brain. Even though they had challenges from the beginning, now we've got something new going on. And so for the very first time as a world, we are starting to deal with the outcome of living well and living longer with developmental disabilities. But now we're living a full lifespan. And once you live a full lifespan, then this thing called dementia is a possibility. And because frequently folks have had to be on a number of medications or treatment protocol, or they actually had some problem with their brain early in life, it turns out their risk of having dementia is either equal to people who don't have developmental disabilities, or even much greater in some cases. So with developmental disabilities, I'm going to go ahead and use that term, intellectual disabilities, people differently abled. Again, looking at that population that I've described, if we talk about Down syndrome as a separate group, and we will talk about Down or Down syndrome, or the older phrase of Down's syndrome, we're going to talk about them a little differently because that population, that group, that particular genetic code has a different profile. But for everyone else, as far as we know, some discussion about autism now, people who are developmentally disabled or developmentally challenged, about 5 to 10% of that population will also experience dementia. But the reality is, what we're finding is that frequently it's starting to affect folks a little younger than we might see in the general population. So sometimes what we're seeing with greater regularity, and again, it's a relatively new population, people who are in the 45 to 60 age range are starting to show us signs that what they're experiencing is early signs of a dementia. And the dementia has gone from a brain-changing condition to a life-changing condition. It particularly increases if that individual has a history of having had head injuries that are significant, if they have family members who have Alzheimer's disease or other forms of dementia and it was a genetic code for that family, or that they have other multiple risk factors, things like cardiac disease, things like respiratory disease. So if they have some other risk factors, their rate of developing dementia goes into a higher risk category. And again, what we're seeing is we need to be more curious and more interested even at younger ages, because what we might be looking at isn't a behavioral disturbance. It isn't exactly a health disturbance. It's a life change due to the beginning of their dementia starting to impact their life, not just their brain, but their life. Now, when we talk about Down syndrome or Downs, this is really significantly different. The research is demonstrating that at birth, when people have trisomy 21, which is what Down is, they get a multiple copy of a certain chromosome. All gene phenomena is on that chromosome. And so what starts to happen is at birth, people living with Down start developing beta amyloid plaque formations and tau pathologies, but not process going on that apparently the increased risk of dementia occurs, particularly Alzheimer's disease. So what we think might be happening is people who have Down have premature aging. And so what we're seeing is a younger age of onset for Alzheimer's in large numbers, but also a higher risk for some other dementias at younger ages as well. So somewhere around 35, we might start seeing some symptoms in some people. By 65, we are seeing a large number of people, if they're still alive, are starting to struggle with the impact of living with dementia in addition to developmental disabilities. Now, Down syndrome. And for some of these folks, they actually live out their life and not know a symptom of Down. And in other words, just like in the general population, what we've seen is that some people who have beta amyloid plaque formations in their brain, and they're pretty significant, it doesn't actually affect their behavior in real life, either because they have compensatory strategies or their life is fairly simple and routine, and so it just doesn't show up until they die of something else. But with people who live with Down syndrome, what we have started to notice is there seem to be a couple of progression patterns, and one pattern is really distressing because it is a very rapid onset of symptoms and progression. And so those folks could last as little in life from 1 to 3 years from when we see the first symptoms that change their life to the end of their life. And that's tough because that means week by week, month by month, we're seeing shifts that make it harder and harder to support them as they've always lived and to give them those opportunities. Now, with most progression patterns, we're talking about 3 to 10 years. It's a little shorter than the general population norm. And we may also see more people with Down be less able to do things sooner. And that may have to do with sort of baseline but it may also have to do with muscle tone and the ability of the brain to manage the body. And it's always been a bit of a challenge, and it's always been some struggle. So it may turn out that the ability to resist gravity, the ability to manage chewing, to do the muscular work that you need to, people with Down syndrome tend to have a lower muscle tone in general. And so that may actually impact and cause this problem to look somewhat different. It also means that they have other things that we might notice first. In general, people who have Down syndrome also tend to have other medical problems, heart conditions or respiratory conditions or other health issues, cholesterol level problems. And because of that, it's sort of an impact. Not only do they have Alzheimer's, they may also have vascular dementia. So it could be not just one dementia. They could have a couple cooking at the same time. Some of the unique changes that we might see in a developmental population, because people who live with these changes don't exactly look like the regular Joe Schmo on the street, is the first things we might notice are not memory problems, because memory's always been, short-term memory, immediate recall has always been an issue. Spatial orientation, ability to wayfind has always been a bit of a challenge. If that's the case, then what we might first notice, which we could notice in a general population, but we miss frequently, is attention to task. And the attention could be hyper focus on tasks again, or for the first time, or inattentive and very much a busy bee getting distracted by everything. So the two attention phenomena that we want to notice a shift in is busy, busy, busy all over the place, can't focus, or so hyper focused, I totally ignore everything else going around me. Which makes my life start to fall apart, because the expectations are I will pay attention to the world and not pay attention to my sensory driven need, or my desire to listen to this piece of music, or my desire to watch this TV thing, or my desire to engage with my hand. So some of the kinds of things that I might have historically done during life changes or high stress, you might see me doing more as a routine, which has to do with my ability to pick out and pay attention and shift attention, shift focus. The second kind of change you might notice is my self-care skills. You might notice that my ability to manage my care routines is starting to slip a little bit. And at first it might be chaining the entire sequence together, because that was actually the last thing I ever got, was the put it all together and make your day work. So what's happening now is I'm doing parts of it, but I'm skipping parts of it. So maybe I am eating breakfast, but I'm not brushing my teeth. Maybe I'm brushing my teeth, but I'm not brushing my hair. Maybe I'm putting on my clothes, but I skip the underwear part. So it could be the entire sequence. It could be pieces in the sequence. Typically, it's not a motor skill problem. It's attention again. But I could be putting on 5 layers of clothes, or I could be putting on very limited clothing. I might not be changing clothes. I might just be wearing the same thing over and over. Again, not totally unique for other forms of dementia and other populations. But in this one, because it took so long to learn those routines and they're so routinized and habituated, what starts to happen is people start to argue and fuss about these pretty quickly, because it's pretty noticeable. And so it tends to be a bone of contention. And unfortunately, what it starts is a chain of events where my distress level gets pretty high pretty quickly if I'm the person you're trying to help, or your distress gets pretty high pretty quickly because I'm not like I should be. And we already did this a long time ago. And it's hard to understand why that's shifting. You may start noticing seizure activity. And the seizure activity may not be grand mal seizures, may not be massive seizure, but it may be just little staring episodes or little loss of awareness. And it's sort of like, if you look at me, I look blank. And I can also lose my balance when that happens. When I come out of that state, I can't find gravity. And so there's a higher risk for falls for me, but there's also a higher risk that sometimes we start to notice these events around doorways or transition points, a point when my brain has to shift the visual picture internally as well as manage my movement into it. So let me say getting on or off a bus, getting in or out of a doorway, on and off a toilet. So you'll see during transitions, it appears that I freeze and I don't do anything. And that's frustrating. It's also somewhat confusing. Because what ends up happening is people behind me, if I'm with a group of people or there's a transition period where we're all moving from place to place, somebody pushes me or tries to move me out of the way or touches me, and then I go into high distress. And so we end up with an incident, or I actually lose my balance and fall because I'm not actually present in ability to manage my body in those moments. It is an actual seizure, but it's not highly registered. And again, one of the immediate knee-jerk reactions, if we're not taking a time out and going, whoa, whoa, hang on here, could be to increase my seizure medication, which actually also then possibly will increase my fall potential and my decreased ability to attend and pay attention to what's going on. So this is where we get into these little cycles of trying to fix something without taking a big step back. We might actually be making everything worse because we're not noticing what's actually driving what. We also notice that memory problems are probably not the thing you're going to notice first. What you might notice is repeated questions, repeated statements, repeated requests over and over. But what you'll probably notice is an increase in frequency or intensity, not necessarily that I'm having a new problem internally. So your thought is, Teepa, what did I tell you? We talked about, you know the rules. What time is break? What time is break? What time is break? What time is the break? And it's like, Teepa, look at the clock. Look at the clock, Teepa. And it feels like we've gone backwards. And you, again, people will frequently describe, she's just really not even trying. And it's like, so not true. I really am trying. I really just don't have capacity. And because there's a history of having learned this way, and it took hard work, and you had to figure out the hard line and the support and all those things that made this happen for me, you'll try to go back to old habits. And that's the big timeout, because I'm not that way. You're not training me. You're having to help me figure out, so now what? You may notice people actually stop trying to speak so much, which means they might go to physical action, because it's not that we don't do something, it's what we do changes. So we might notice people physically doing things with their body rather than asking for things with their words. So you may see me reaching out and taking things, or moving places, or just grabbing things, or becoming emotionally distressed with greater frequency. And again, the old phrase of use words, you know your words, use your words, Teepa. All that's going to do is aggravate both of us, because that knee jerk of she knows better, she can do better. I can know better, but I won't necessarily be able to do better with my language, because it's a highly skilled phenomena that requires really quick, rapid turnaround. So you may notice that my speech is more slurry, because my ability to articulate and to produce sound with each articulation could be more impaired. That actually requires diaphragmatic work. It also requires vocal cord work and the fine detailed movement of my lips and mouth. And with Down, typically people have a smaller mouth with a larger tongue. And often the attachment of the tongue at the base, down in the floor of the mouth, is up closer to the tip. So from childhood and birth, they have always been a little less clear. And it's a little less clear because I don't have a freedom to probably move the thumb. I can't move my whole tongue. I only move the front part of my tongue, and it's a little thicker. So if that sounds sort of familiar, that speech pattern sounds sort of familiar, it's because if I thicken up my tongue and I don't let it move as freely, that's what it's going to sound like. So for those of you who've lived with me a long time, we get used to each other, and I articulate as well as I can, and you listen as well as you can, and we figure out how to communicate. And what you might start noticing is no matter how hard you hear, you just can't quite get what I'm trying to say. And I'm having a harder time both getting the words to come out mechanically, but I'm also having a harder time thinking about what it is I want to say and making the thing, the thing, the thing, the thing, the thing, the ticket, the ticket, the ticket, the ticket. I love the ticket. You gotta go to the lady with the lady, go to the lady, go with the lady who sings. So I want the ticket to go see the lady who sings. In other words, I want to go to the concert. I can't find the word concert. I love to go to those concerts. You know that. But now I'm having trouble getting articulation, particularly consonants or those hard, sharp sounds. But I also am becoming very emotionally distressed, and I start repeating words. But it's not clear to you, and so it's just calm. Tipa, stop. I need you to pause, listen. And all that does is make me more just that, oh, and then I shove you, and then suddenly there's an instant report. And let's say you're a friend of mine, and you also have Down syndrome. Yeah. So much for our friendship. Hey, that mean, I don't know what I'm with her. He's a crazy. He's a crazy woman. Have issues with caregivers and issues with staff and issues with parenting. We also have issues with friendship because people see me and they're like, what is going on? I don't want to be around her. She's mean. Because the ability for me to be like I've always been is changing. And like, she won't talk to me. She looks at me mean. I'm not actually looking mean. I'm looking confused, but it's my facial expressions are also not as clear and sharp as they used to be. That's all fine motor.
So hi guys, I'm just popping in because the next little bit of this video had some technical difficulties where there was some issues with the audio. So Teepa was talking in this section about some of the changes that you see in folks with developmental disabilities and dementia, and that how it might show, right? So she was saying that the person with developmental disabilities may be doing things like rocking and clapping, laughing and grinding of their teeth, things that they used to use as ways to try to calm themselves. And what it's to you, it should be a sign of acute distress, right? And that I, as the person, can't manage what's going on. And so I'm reverting back to some of these things like rocking, laughing, crying, grinding teeth. I might also bite myself and cause other things to happen. And that what we as care partners, some of the challenges we have in this is that we start trying to, oh, it's time for a behavior plan. And the thing is, what you probably will end up doing is fighting amongst yourselves about the fact that, well, somebody's not following the behavior plan, and and it's us that are having the problem. We can't. So behavior plans will only work if we're the ones who change, right? And if we help to change the environment and our expectations of the person with DD and with these beginning signs of dementia, because it's the dementia that's taking over in this situation. So hey guys, I'm back for the end of chapter 1 about taking a time out. So what we talked about in this section is the fact that we as care partners need to notice what's different. Did you pick up on that? The fact that we need to explore the environmental factors for our person, the interaction factors, and the person factors. So things that change, and that we as care partners need to be a little bit more aware that the things that we're seeing or the behaviors that we're seeing in our person may not really be a behavior, but may be a sign of something different, right? Some kind of other changes. And then the other thing that Teepa talked about in this section, I'm going to give you guys some time to think about that, but then she went into a section about talking about the risk factors and the fact that folks with Down or Down syndrome are affected differently than people who don't have Down syndrome but have some other kind of developmental disabilities. And so but what we do know, or what we're starting to see, is that about 5 to 10% of the DD population are now being affected by dementia. And here are the increased factors, right? It increases after the age of 45 to 60. That's when we're starting to see these signs. They have an increased risk if they have had a history of head injury, if family members have Alzheimer's disease of the genetic type, and if there are other risk factors or other health risk factors that are involved in their life that may increase their risk. So lots of things to think about. So I'm going to pause here and take us to the next chapter, where we're going to start talking about the different types of dementia. Okay, see you a little later. Hi, welcome back to chapter 2 of Dementia and Developmental Disabilities. In this section, we're going to be talking about the different types of dementia that tend to affect the developmental disabilities population. I also wanted to let you know that there were some technical difficulties in this section as well from this recording that we were not able to fix. And so we are aware of it, and I'll just let you know that they happen. And then Corey, who's also recording it, let Steepa know that there were some problems. So she will come back and restate some of the information. I'll see you in a bit. Bye.
Another piece to keep in mind, particularly with Down, but also with all forms of developmental disabilities, is we've got to get out of this idea that everything is Alzheimer's and everything is going to look like memory problems. Because if that's how we're looking at things, we're really going to be missing a lot of folks who are showing us early signs that things are shifting. So the four groups, that I want to make sure we're checking out and paying attention to, particularly for people who have developmental disabilities, is number one, young onset Alzheimer's. That's certainly a high risk category. The second one that we tend to underestimate, and that recently has come to light as a high risk for developmental disabilities, particularly, is vascular dementia. And that is primarily because vascular, although it's not a brain disease, it is the blood supply and oxygenation to the brain and the nourishment of the brain and waste product removal of the brain. That disease is high risk when we have people who've already had brain damage. These are autism, people who might have problems with cardiovascular disease. Those are folks who, due to their developmental disability at birth, they started having issues with the brain and how the body and the brain, the communication between the two, in terms of blood supply, oxygen supply, and nourishment, making all the organs work the way they should. And because there have always been message issues, their risk of vascular dementia panel might act significantly. And a lot of what we thought was Alzheimer's in some cases might actually turn out to be problems with the hardening of the arteries in structures within the brain. Having problems with blood flow, with structures in the brain, having problems with sugar metabolism, glucose metabolism, with structures in the brain. Now, frontal temporal lobe dementias, we typically will see also some folks have frontal temporal type dementias, which means either a frontal variant or a language variant or a combination. And the one that gets missed the most frequently is people who have developmental disabilities who develop diffuse Lewy body disease or Parkinsonian type dementia. Lewy body is where we see some hallucinations, or a lot of sleeping or very little sleeping, difficulty with movement, but also heart rate, those kinds of things. Because I think all too often people think developmental disabilities and they think Alzheimer's and they stop there. And really, in fact, we need to have that timeout and that pause. Be curious about the possibility of other issues going.
Teepa, can you time for just a moment? We're having a technical issue. All right. Go ahead. Sorry about that. I just wanted to see if we could.
Okay. No problem. That's not to say that we do know that some people with developmental disabilities, part of their genetic syndrome is actually development of dementia at a very young age, and they may actually begin to have their symptoms of dementia in their teenage years. Adolescence might be the onset for those folks. We also know they're at higher risk for metabolic issues due to, again, some of the complex cases. And finally, some people might actually be starting to use alcohol in their adult years. And for developmental disabilities, the addition of alcohol or drugs can increase the risk of having problems with dementia at a younger age. And then mental health conditions also, or infections, might also impact this. So not unlike the general population, but again, getting people to step back and realize this isn't a young person anymore. This is an aging individual. This is a full-grown adult who might have the risk patterns in place, and we've totally missed it. So what we know with Alzheimer's is your brain shrinks, it shrivels, and so much of it dies that you can't run your body. Now, when somebody already has a developmental disability, what's different is that there were parts of their brain that didn't work very well from the very beginning. So those might be areas that from the start might have looked different, or they might have really shriveled and shrank. But the difference is the rest of their brain should still be vibrant and full and large and sending messages and receiving messages and doing its work. So it's a little bit different than the kind of thing that we're going to see start to happen when people start to develop these problems. And historically, we've always looked at PET scans of normal versus Alzheimer's disease or other form of dementia. We're just now starting to get that work done over mostly at UCLA and at Johns Hopkins. There's a lot of work and some work in England and Scotland as well, actually looking at brain activity for people who have different developmental disabilities and are able and willing to participate in research studies so that we can learn more about what their brain patterns look like. We don't have a lot of data, but we're starting to collect data. By next year, I'd be able to do a different talk, and we might actually do a different talk because more is becoming available just about every month. With vascular,
Deepa,
yep.
Is it possible for you to just go back and quickly retouch the Lewy body? I think that during that segment, we were having a lot of audio and some freezing, and so people didn't get all of that information.
Okay, for sure. So with Lewy body, the thing that we want to pay attention to is frequently these individuals who have developmental disabilities may appear to have psychiatric issues, and they may be treated as a psychiatric condition, when in fact what they're experiencing is Lewy body. Things as visual hallucinations, seeing and experiencing people, animals, bugs, or children that aren't there. Sleep disturbance that can be extreme, either oversleeping or under sleeping, or moving around when they're sleeping, being up and walking, even though they're not consciously aware of doing that. The freezing up, being unable to move, or sudden loss of blood pressure, blood sugar, heart rate, and looking like they're very, very ill. They may be having a heart attack or a diabetic episode, and in fact, what they have is diffuse Lewy body disease. Being unable to respond accurately to pain indicators or to be hypersensitive to distress and pain, which frequently, one of the first things many people report is they don't like taking showers anymore. They refuse to take showers. They refuse to wash up. But if you combine a lot of things together, Lewy body makes it really difficult to really enjoy a shower. It also makes it more difficult to consume food because your sense of smell is frequently impaired. So what I'd say is with developmental disabilities, it's very, very, very frequent. Probably about 95% of the time, Lewy body will not be identified, and yet Lewy body will be present. Estimated about like the general population, about 30% of all cases probably involve some Lewy body, some nuclein protein malformations. So let's go ahead and move forward a little bit, and I'm going to open it up for questions in a second. With, let me go back. When we're talking about trying to help people live their life well, right now I've been talking about we have someone in our life or someone we're caring for that already has the condition. But if we were to take a step back and look at some of our younger population who are living with developmental disability, the question is, how well are we helping people live so that their risk actually goes down? Because reducing risk should be something all of us are looking at, because right now that's our best bet. And when it comes to developmental disabilities, let me just go through the current list that everybody gives you and see what could we do that doesn't result in distress that might help someone. So what we know is having fun and maintaining mental activity while you do it. So doing things that are fun for your brain, healthy. Aerobic exercise, 5 times a week for about 20 minutes or so, healthy for your brain. Getting the eating, quote unquote, eating vitamin E, not taking it, eating vitamin E is good for you. But you don't want to get carried away with it, but maintaining a level of vitamin E, vitamin C, your vitamin Bs. A heart smart diet is generally recommended for reducing risk, and watching your omega-6s, going with more omega-3s, lowering your weight a little bit, because fat, adipose tissue, carrying it around is not good for your body or your brain. Trying to reduce or not smoke. Find something else to do, oral motor, that sort of satisfies you. Sleep, pay attention to sleep, making sure you're getting it, particularly with Down syndrome, something that we're starting to notice, sleep apnea issues. But other developmental disability as well, that sleep could be a bit of a problem when we just totally didn't think about it. One of the things to realize is that you don't need to snore to have sleep apnea. Really paying attention to sleep apnea might make a difference. De-stressing. But finding enough in your life to keep you going so that you're not bored. So the idea of not being stressed out, but also not being bored makes a difference as your risk. Iron within limits, homocysteine, pretty much decent. Staying socially active at a level that you're comfortable with. Now, it could be you just have one-on-ones or small groups, or it could be you have large groups, but staying socially active. Getting depression treated, anxiety treated, but not just with meds. We're talking about a full treatment program that involves trying to manage meds, but also trying to really look at how you're treating yourself, and do you have talk therapy or interaction therapy. Controlling diabetes and hypertension. And at this point, folks are recommending still for the developmental population, but I think there's discussion, statins and non-SADs. So for pain, for managing hypertension, people are still currently making these recommendations, but it's something to keep up with and pay attention to for risk reduction. And the last one, which we'd all like, which is why we want to watch what makes people fall and have fall-related injuries, is preventing head injuries. Because we know that if you've had one, we certainly don't want to have more. So those are risk reductions, but they're not just for developmental disabilities, but I just want to mention them. So I'm going to pause here because I want folks to just sort of think about those things and ask questions.
Hi, I hope you enjoyed this chapter of Dementia and Developmental Disabilities. I just came in to give you kind of a recap of what we heard in this chapter. So Teepa mentioned that dementia looks very different for this population. It shows up more in behavior changes or the ability for someone to follow sequences and things that they used to do and how they learn things, right? But she also talked about the types of dementia that we see more prevalently in this population. So just a reminder of those. We have young onset Alzheimer's. That tends to affect the Down population a lot more than the other population, but it's there. We also have vascular dementia, the Lewy body dementia, and frontotemporal lobe dementias. Those are the 4 that we tend to see a lot with people with developmental disabilities. So we need to kind of learn as much as we can about these different dementias and start to see those signs instead of maybe thinking it's a behavior change or a behavior plan modification need. And then the other things that we talked about in this chapter were the fact that we need to do risk reducers because they're important for people with DD just as much as the other population, right? So the things that we need to be more aware of, though, with our folks with DD are that a heart healthy diet absolutely is important, along with various vitamins and minerals that they may not get in their foods or through actually just taking the vitamins and minerals. We actually may need to ingest them in different ways. Physical exercise, of course, is always going to be important, as well as brain exercising, and then staying social. So we need to find opportunities for our folks to do those things so that they can possibly reduce the risk of getting a different type of dementia, along with other life issues that we're dealing with. Okay? Hope you enjoyed this chapter. I'll see you back later for chapter 3. Hi, welcome back. We're now in chapter 3 of Dementia and Developmental Disabilities. And this particular chapter is when Teepa opened it up to Q&A from the folks that were participating in the live webinar. See you at the end.
So let's just open it up for a bit here, Corey, and see what we've got to say about developmental disabilities and dementia.
Pam was asking if she was wanting to know a little bit more about how smoking increases risk.
It has to do with nicotine is a brain stimulant, but some of the carcinogens and some of the problems that we have, they change brain blood flow. Smoking affects your oxygenation of your tissue, and it starts to modify how your lungs manage oxygen and transfer into the bloodstream. And when you do that, ultimately every organ in your body struggles. And a place that it really shows up is in the brain. So although you're taking in a chemical, with many people when they smoke, they take in nicotine, and nicotine is a brain stimulant, but the delivery system is a risk pattern for changing how your brain cells are getting oxygenated on a regular basis. And it has a lot to do with what we're doing between your lungs, your heart, your blood flow, and then getting it to your brain. That's sort of the really simplified layman's discussion of it. It's highly complex, obviously, but it increases risk because it puts those brain cells at risk for not getting oxygen and not getting the nourishment that they should, because it's all about blood flow.
Brenda.
Okay, I had a question, Teepa. You mentioned that the seizures or the staring episodes that frequently one of the interventions will be to increase their anti-seizure medications. And you said that that's problematic. And I'm assuming, but I don't know, so my question is, are those anti-seizure medications, they don't affect the seizures caused by the dementia? Is that correct?
The challenge is they might actually affect them a little bit, but they also impact the rest of the brain. They're not specific to managing seizures. They actually affect firing in the brain. And so what they do is they slow the person a little bit. So although they may be less seizure prone, they're also less able to resist gravity, because gravity is a constant force, and it's a moment by moment adjustment that our brains and our bodies have to make to gravity. So when I make you a little slower to respond, which many seizure meds have the impact of, if we're trying to fine tune a brain that's having issues and being impacted in a way that's not just chemical but also structural. If we're trying to keep that within a fine line, it's really easy to step to the side where now they're not able to get their foot up fast enough to catch their balance quick enough. And so what happens is they fall, and they fall with impact. Because I don't have the time to put my arms out. I don't have the time to just bring my foot forward and not tumble. So it turns out that by increasing those meds with folks, we have an increased risk of head injury, of trunk injuries, but also of, just not being able to actively participate as well. And
Okay.
It's that kind of thing. So yeah, you might get a little less seizure activity. It might make more sense for us to actually start walking with the person with a hand under hand support, so we notice the pause moment, and either see if we can get them to focus on us going through a doorway so there's no transition. we're still with them and we're still moving with them, so that they don't see it as a new location because we're the constant factor. And so really focusing on me means that there is no difference in environment. And so your brain doesn't have that, oh, geez, what just happened here? Pause, freak, I can't think, seizure, because not so much data is trying to switch gears. It's almost like you have to flip the switch. Look, I'm in a new room. And if someone is with me and transitioning me to the new room, I notice the new room in a different way. My brain doesn't have to take it all in at once and determine where I am and what I'm supposed to do at the doorway. Does that make sense?
Yes, it's very helpful. Thanks.
Yeah. So looking at what intervention we do, not that meds aren't indicated in some cases, but frequently we go overboard on them, and then we're fixing all kinds of problems related to them.
We've got one more from Heather.
Sure.
Have you seen people using the NTG EDSD as a screening tool? And if you have you seen it working, or how is that working?
There are some new screening tools that are out for developmental disabilities. Tell me them. I'm not good with initials, so you'll have to give me the alphabet soup, because I don't do well with, I'm sorry, alphabet soup and I are not a good match. So you'll have to give me the formal words for the assessment, because I can't think of them quick enough.
Okay, it is the National Task Group of Intellectual Disability. It's an early detection device.
Yeah, and yeah, I actually have seen a little bit of that. I've also seen one out of England, and I have seen one international one. Mostly what I have seen is we're starting to look at functional abilities rather than trying to identify an intellectual shift, which I think is a healthy one. The problem with all of them is if somebody doesn't have an accurate baseline, it's difficult to notice a change in someone, just as the issue right now, nationally and internationally, is if you don't have a baseline, how do you know if I'm changing? So if there's a baseline established for someone, then early indicator systems make sense. If we do not bother to establish a baseline that looks across the spectrum, then when the time comes to say, is there a change from what? A good day, a bad day, the range of possibilities for someone. Because I think with developmental disabilities, what we know is that people do have good moments and bad moments and good days and bad days to start with, just like every human being does. So is the testing phenomena familiar enough that the testing phenomena in and of itself doesn't trigger a behavior that is inconsistent with what I would see in their daily routine? But if I just use observation of another, I'm assuming the other person is accurately observing me and paying careful attention to what I'm doing, and not on automatic pilot, and not assuming that my behavior is my behavior and it's not a brain change, or looking at every single thing I do and thinking it must be a brain change because she didn't do this yesterday. Well, what have I been doing? Do I have this level of variation? So the tools are starting to be developed. I think we're in a very, very early stage of development, given that we've just recently discovered, look, people are aging and they're getting dementia and we're not sure what to do. And I'm not talking about developmental disabilities. I'm talking about the general population. So I'm not being dismissive. I'm simply, I would rather have two people who know the individual well and are willing and interesting to take a step back and really share with me what kind of shifts they've noticed, and then spend a little time with the individual to see what I notice, than looking at a formal form right now. That's not to say that they aren't used and they aren't useful. It's just really looking hard at how can I apply them to someone if I've never really worked with that person before, and if the people who are around that person may not know them that well.
Right.
That's the challenge, frankly.
Thank you.
Yeah.
So hi, I'm back. I hope you found this chapter interesting. There were a lot of very interesting questions that came up in this section. the idea of how does smoking increase the risk, or how is that involved in dementia and other things. Teepa also talked about the fact that seizures might start happening, or we may see them, and that they're a little different, if the person has kind of like a vacant stare. She talked about the idea that if people are experiencing these seizures, they are at an increased risk for falls because people around them aren't aware what's going on with them, and they're not either. And because they tend to have issues with balance anyway, because the motor strip isn't necessarily working properly, this can also cause other problems. But a big part of this section was talking about the fact that why we're having so much problems, or so many problems, with even become aware of the fact that dementia could be part of the problem, is that we don't have any baseline assessments. We don't know where the person was or is to decide if there's a change. So a lot of what we need to start thinking about is maybe getting some baseline assessments of people early, and also use our observation skills to begin to notice when changes are happening. Okay, that's the end of chapter 3. See you back here for chapter 4. Welcome back. We're now at chapter 4 of Dementia and Developmental Disabilities. And this section I found kind of fascinating. Teepa's going to do a bit of a role play here so that we can kind of see how dementia looks different for someone with developmental disabilities. And then we just wrap up the session. So I'm going to pop in a little later to ask you a question, and then we'll wrap it up.
The important thing for developmental disabilities, just as it was when we first discovered folks were going to be a little different, is for everything they don't have or everything they lose, there are things people keep. And what we're always going to be on the lookout for is, how do we use what they have? How do we support them in that moment? And how are we prepared to change because they're changing? And that is a very different pattern in direction of travel for people with developmental disabilities. One of our greatest problems is that we've worked really hard, and so have they, to get where they get. And to think of them now losing those abilities is really hard. And so the idea of being supportive, but not holding on to something that's not there anymore, is a difficult thing. And being able to let go in a moment, but if they show me the skill later today, then I take it and use it, means that my care plans can't be as concrete and rigid as they used to be. And that's very different, because we are used to developing individual education plans and individual life plans and individual care plans. But what we tend to do with developmental disabilities was we make them pretty rigid. We tend to have rules about how much help and what kind of help and where you stand and what you do and what you say and what you don't say and what they do and what the behavior is and what the outcome and what the reward is going to be, or what the benefit for them doing it is going to be. And that's not going to work so well when we're talking about a disease state that varies from morning to night, from person to person, from day to day, from moment to moment, not because of anything that I can necessarily predict, but the chemistry of the brain and the structures of the brain and how well they're doing their job in that moment. And so this is going to require a new flexibility. And one of the greatest challenges I feel we face is that what we've done is taught people to be fairly rigid in how they approach and engage people with developmental disabilities, so that there's not a lot of variability in their life, so they can perform to the best of their ability given an environmental and a support structure that's consistent. And historically that worked. But now that they're changing from moment to moment, from morning to night, and from day to day, that's not going to be as effective as it was. And we're asking everybody to do a huge gear shift here, and to have stability when they need it and flexibility when they require it. And so this is totally not in people's wheelhouse. And it's not because they're not good people and they're not kind people and they're not caring people. It's just not what I've done. That's not how we do things. This is what we do. We have a care plan, you follow the care plan. They have a work plan, you follow the work plan. They go to the day center these days. They go to the workshop those days. This is their routine at the center. This is their routine at home. And what's the struggle for us is, yeah, it was, but now it isn't. And how to have stability with flexibility is probably one of the biggest problems, because that's not where we've come from. And it's a very different way of looking at things. And so letting go of what we've used before to realize we're going to need something different, because the brain is changing. The brain is changing. So I thought I'd start a little bit with, we're starting to get those questions, because that's a pretty common one. And we're going to use our positive approach responses. And Manda, are you on the call and are you available? Because I happen to know you can do this one relatively well and you have some experience and background with development.
I'm here. I'm available.
Okay, cool. So I'm going to be a fairly high functioning person who has gone and worked at the workshop for a long period, or worked at McDonald's for that matter. I'm going to be working at Mickey D's. And I am somebody who greets customers. I am somebody who does table management, and I keep the place clean. I can do French fries. I also cook French fries I do the fryer. I know how to do the fryer. I also can manage. I don't do the register, but I do fix the drinks, and I can do the drinks. Okay, so those are sort of some of the descriptions of things I can do. That's what I've always done. So you're my job coach. Okay. And you've been asked to come in because I'm exhibiting some different behaviors. So Corey, you're going to be another employee. You're the person who runs the register. Okay. All right. We're going to watch. Corey, what soda did you say? What soda did you say?
We need a large Diet Coke.
Large Diet Coke. You want me to do a large Diet Coke?
Yes.
Anything else?
No, just a large Diet Coke.
Okay, so I think a large Diet Coke.
Yes.
Okay.
Tipa.
Yeah.
I need that large Diet Coke. Can you get that?
Yeah, a large Diet Coke. I'm going to fix a large Diet Coke. Do you need anything else?
No, just the Coke, but we've got customers waiting, so.
Okay, you got to get it done fast. You know that.
Yeah.
Yeah, I'm going to do it.
Everybody. Okay.
What do you need?
A large Diet Coke.
You want a lid on it?
Yes, please.
You want a lid on it?
Yes, Tipa. We'd like a lid on it.
What kind of Coke?
A large Diet Coke.
Who wants it? I'll give it to him.
Okay. It's the lady.
Okay, pause. So this isn't my normal behavior. I mean, and so Corey's like, the manager called because she wants the job coach to fix me.
Hey, Tipa.
Hi, Nana.
Hey, how are you doing today?
I'm doing great.
You're doing great.
I work with Corey. Corey is my friend.
Corey's your friend, and you're doing a good job working with Corey.
I'm making her sodas.
You're making her sodas.
Yeah, I do what she says. I'm very good.
You're very good at what you're doing.
Tell me I'm very good.
Absolutely, Tipa.
I love my work.
I know you do. You do love your work.
I fix sodas.
You do. You fix sodas.
Yeah, I'm a good fixer.
Yeah, so Tipa.
Yeah.
Yeah.
I like Corey. Am I a good fixer? I like you, Corey. You are my favorite person to work with.
Yeah, Tipa, you really like working with Corey,
I like working with Corey.
Hey,
Corey,
Tipa.
Corey, good to work with.
Tipa, come with me. Let's go over a little bit further from Corey, over here, so I can hear you a little better.
Okay.
Okay.
So, pause. So now, what did people notice happened to me when my boss showed up? Anybody want to, Brenda, do you want to jump in here and tell us a couple things you noticed?
I was going to say, you were kind of bragging, like I'm doing a great job, right?
Right. I really did my energy go up or my energy go down?
Up.
What else told you my energy went way up?
You were talking fast and it was very hard for Amanda to get a word in edgewise.
Yeah. That's true. And what else was I getting? Was I a little louder?
Yep.
Yeah. So I really wanted her to know how good I do, because when she comes, it's important that she know I do good. And my speech, I got a little clearer. I was a little faster, but now I was focused not at all on what was going on. And so Amanda's going to have a really hard time trying to help me, because she's the visual trigger that triggers me into wanting to perform really well. But she gets me so excited that I'm literally not able to think in that moment. All I want to do, I love my job. I love Corey. Something must be up. I don't know what it is. My distress level's up a little bit, and I am so anxious. I'm not taking in hardly any data. I will go with Manda because she used gesture and she's moving me away. But Manda's probably not going to be able to be very effective at helping me figure out what I'm going to do. She can spend some more time with me. But so as a team, what are you thinking is something we need to pause and realize?
Well, as the coach coming in, I'm not going to be able to plan with you right now in this moment, because I'm not going to get an accurate assessment of what's going on, knowing that every time I come in, things look different than they normally do. And if Corey's saying that when I come in, well, she's not really like that. That's different than how I know that I need to do that separate team meeting first before I can really even talk to you about what's going to feel good for you and planning wise.
Right. So if you use your experience with me, Manda, you're going to be fixing the wrong problem. You're basically going to be trying to get me to calm down, and calming down isn't the problem. That's really not where the issue is. The issue is I can't hold on to Corey's data while I'm being surrounded by a lot to do. And I described that I actually have multiple jobs that I've done. And so whatever we're coming up with behavior plan wise or job work wise for me, it's probably going to be ineffective, because what we aren't doing is figuring out how you're going to make me still feel valuable and important, which was obviously very important to me, but to reduce the demands of the fast turnaround and holding on to auditory information. And what happened to my ability to take in the visual data that's always up on that screen? Well, perhaps I'm at a place where my visual regard when I'm active is fairly binocular. I'm in the moment and I get it, but I can't hold on to it. And when I turn to do it, my brain can't remember the data I got, whether it's visual or auditory, to do the task. And training me to do that over and over again would make sense if you were training a brain that's stable. But if you've got a brain that's now starting to be unstable, continuing to do this with me is going to really create high distress for Corey, for me, and for my trainer, let alone whoever else I'm living with, because whatever's happening at work, what do you think then would happen at home or at where I live if instead of having a good experience at work, I had a hard day at work and then I get home? And that's where I want to be friendly and familiar, and I want to do my routine and my habit. And when I get home, somebody says, we're going to have spaghetti for dinner. No! And I have a meltdown, and it's like, holy moly, what is going on with her? And so it's all tied together. But again, my inability to have ever been able to put all the puzzle pieces together to figure this out, and having relied on a team my whole life, now my team needs to step back and realize, okay, even though she can sometimes do this, how flexible and how stable can we create a job for her? And how are we going to do that? And what level of commitment do we have to doing that? Because the reality is, as my condition shifts, I'm probably going to need some job changes where I have one task that I focus on and there's less less distress or stimulation around me so I can achieve it. And I'll probably need a partner. And so all of a sudden, for me, part of my whole life falls apart. To me, it feels all of a sudden people don't want me doing things I've done. So how will we maintain my sense of self and self-worth? Because I may only be in my 30s or 40s or early 50s when this is happening. And I have incredibly young onset, and I'm fairly functional, because it means I can't have my own apartment now. I can't ride the bus on my own now. I mean, why not? I've always done that, but I'm getting off at the wrong stop. So this creates a new pattern for us that we haven't really dealt with. So let's now try this next phase, which is, let's say, Amanda, we've worked a little bit, and what I'm going to do is move just into the front area. I'm going to work on clearing and cleaning and making sure the front area looks right, and being social, because I like to be social. And let's see how that goes for us. So I'm gonna work out front, right?
That's right, Teepa. So what you're going to do, remember, you're going to say hi. And when people come in, you're going to show them to the line. Okay. And then you're going to go back to the door so that you can see the next person coming in, okay?
Okay, so I show them to the line and I go back to the door.
That's right.
Hi.
You just say hi and
I have a question.
them. Yeah.
Can I ask them, are you having a good day?
Sure, you could ask them. You could do a question to them. Sure.
I can ask, are you having a good day?
Are you having a good day is a nice thing to say to people, yeah.
Can I say, do you know what you want to drink?
No, remember, Teepa, you're not going to be taking their order.
Okay, so now Amanda's going to ask me to remember to do these things. So what's the high probability of this working?
Great.
So this is the classic sort of new behavior plan, is we're going to come up with a behavior plan where I can be out front and I'm not trying to do drink orders. But what we missed was the basic problem I was having is I can't hold on to what I just did. And so I love social engagement, and I love to do things right. And I want to get positive affirmation. So this requires us to really think outside the box. So I'm going to put it out there to this group. What do you think we should be doing? Because we've got to figure these things out. There is no free ride here. This is going to be a huge challenge. And I'm high functioning. I'm not the highest functioning person you've ever met, but I'm pretty competent in my life, except now I'm having trouble in my life, and people are feeling like I'm not able to do what I've always done. And I'm struggling, that's for sure. So let's ask a couple people what they're thinking right now. Let's sort of just check in with people. So let's see, who we got there? Hey, Sherry, would you like to weigh in? Have you got some thoughts about what you're thinking about me and what makes sense for me right now? And we'll try to unmute you so we can all hear what you're going to tell us. You and Corey can fight over control. Maybe she can't be unmuted. Oh, there she is.
Yeah.
Uh-oh. Well, she was unmuted for a second, but now we can't hear her. Brenda, do you want to try something since we can hear you?
Well, I just have kind of a response. I think that even though we're talking about persons with developmental disabilities, I think it's typical of anybody probably experiencing young onset dementia with that dilemma of whether they can stay in their job or not. Fortunately, this person has a job coach, so there might be able to be some intervention, but I'm kind of seeing it like chances are, Teepa, you're going to get fired.
Chances are you're right. Because people will try care plan after care plan, work plan after work plan, and pretty soon everybody's getting flustered because they can't figure out how to fix me. And the challenge we face is, okay, they're used to working with developmental disabilities, and they're used to repeat, they get it. And what's happening is you can repeat, and sometimes I get it, and sometimes I don't. And it's not because I'm not trying, it's not because you're not trying. So the big shift here with young onset, absolutely. Now we add on top, we have a history of fixing it by being rigid and just demanding that I get this and reinforcing it either positively or negatively. But now it doesn't really matter that you do that at times. I'm doing the best I can. You're doing the best you can. And this whole new phenomena, and that's really the point I wanted to make, is we're going to need a new game plan. Just like we need a new game plan with young onset and with people living with dementia in the world. Anyway, I still need a value and purpose. How are you going to give it to me when I can't do what I used to do?
So
And
there's
go for it, Nancy.
there's a couple cool ideas in the chat bar.
Go for it.
Pam Spada was saying having signs around, sort of like those companion cards that we hand out that say we've employed people living with dementia or developmental disabilities, and maybe some things to expect that may help the customer interaction. On the other hand, Virginia said one idea was that maybe we could pair them with someone and say that she's training her partner. So she has that value and purpose, but really we've got that one-to-one match. Where there is that support and that person that we'll want to make sure we're giving some time to throughout the day, because it's going to be sort of exhausting to do that all day.
So what we had before is we had three parties. We had the person who was doing the work, the person with the developmental disability, who had a job. We figured it all out. We all worked together. It was all working. And now they have an employer, and the employer was spending a lot of time with them. And the job coach would check in every now and then. And what we're saying now is that these two folks are struggling being with each other all the time. And the job coach can try to do some things, or the job coach can try to do some things, but it's just the skill is changing. So if I'm going to stay at McDonald's or whatever place of employment we're talking about, the place of employment, we're going to have to pull everybody together to have a better conversation about how are we going to support this person who has been among us and is of us, but is really struggling now in a very different way. Are we going to come together and figure out how to do this? Or are we going to say, you know what, they're out. We can't have this. And all too often our society, which I know many of you have experienced, these are the disposable people. These are the people that are like, well, it was fine when they could, but now I'm not sure what to do. And so the idea of partnered or paired work, the idea of creating a place and a space where I still feel valued, and I am valued, and I'm doing something that makes a difference. It's not exactly make work. It's a different way of doing work, that I bring pleasure and I do have joy in my life because of an interaction. But it requires that we really create this flexibility. And the point of the exercise was to show how challenging this can be when we're talking about having open doors and windows and created places and spaces for people living with disability to be present, especially developmental disability. And now to say, well, now you're going to have to make different accommodations. When we don't even exactly recognize anything but Alzheimer's, and we do it sort of poorly and on the large scene, and we aren't sure what to say other than, well, now that you have dementia, I don't know that you're competent to do this anymore. And so I think that's where we are as a society. So
hey guys, I said I would pop in at this section. What do you think about this role play that she just did? Have you seen this anywhere? Is this starting to pique your interest in maybe expanding the knowledge base, maybe sharing this out with other people? Who else might gain some knowledge by watching this clip in particular, but I mean all the clips about developmental disabilities and dementia? Okay, be back at the end.
Any more on the chat bar that I should know about before we move forward?
There's a question about sexually inappropriateness and trying to redirect unsuccessfully. And so I don't know if you want to go into that today or whether you're wanting to wait on that until the sexuality and intimacy workshop.
I may wait until we do the sex. I mean, I can mention that I would back up and ask lots of questions about sensory and inappropriate versus desirable, but not really in this place and in this space and in this time, and some options. And is it aggressive behavior, or is it simply a public behavior, a private behavior occurring in a more public or shared space? Because we got lots of questions, and that's a highly intense topic. And it's not that I don't want to address it. It's just that I think it would take probably another hour to address it well, because we could have lots of issues related to sexuality, both safe sex, but also engagement in sexual, but sometimes just engagement in sensory experiences, be they masturbation or touching of others. I just like the sensation on my hands. And although this was cool, that might be even cooler. Who knows, what might be driving me. Or that I may actually like the feeling of pleasure that I get with masturbation and or intercourse and or sexual intimacy or kissing. And yet at the same time, if I'm being more and more isolated, maybe it's simply the act of touching that I'm seeking, and my words and my behavior is extreme for the degree of loss I'm feeling of intimacy, but I don't actually necessarily want sex. So because we're limited in how much more time we have, I want to sort of address a couple of topics. I mean, we obviously could spend a lot more time on this issue, and probably should, not only as a group, but as a nation and a world. Understanding language. What I would say when we work with intellectual disabilities or developmental disabilities, many of us are fairly skilled at using visual cueing and really paying attention to the idea. So what I would say is this chunk of brain, which allows you to, number one, have vocabulary, comprehension of speech, and speech production. One of the things we know with people who have developmental disabilities, frequently the ability to use traditional language skills has been impaired for a long, long time. And we looked at alternatives. So signing might be an option. Using pictures for action might be an option. And so often we have communication systems that are well established. They've been around for a while for someone. And if that's the case, we want to be aware that we're still using this chunk of brain, but we're doing it a little differently. We're more interested in the wiring than the storage capacity over there for language. So it's not so much the words that are stored over there, it's the concepts. So I'm hungry, whether I'm hungry is said with words or whether I want to eat, which is a sign thing. If I've learned that, or I go get a card and I show you the card, those are all ways for me to get what I internally am desiring and get that message to somebody who has both the power and ability to assist me in meeting that need. So if we were to think through that, it requires that I am aware of what it is internally I want. I then hook it to the concept of hunger, to words, to getting the message, to finding the person, making sure the person is my person, and sharing my message with them. And then when they say dinner will be ready in a half hour, so you need to put plates on the table before we eat. You have a job to do first. This becomes a highly complex back and forth. And again, let me say, the thing about developmental disabilities that makes it a unique challenge is the way we got you to do that stuff was backward chaining. which means we did it together all the way to the last step. And then you did the last step, and we celebrated your success of putting the plate on the table. And then I gave you something for completing your task, and then you get rewarded with the food. And then you get the plate out of the cabinet and you put it on the table, and I rewarded you. So we've learned this pattern of getting my brain to get the concept of I can have an internal feeling, but in order to get what I want or need, I need to do things in the world so that things happen in my world. And that I need to learn the idea of waiting or doing in order to. And the thing about dementia is, whether it's words or actions, my ability, number one, to pick up on internalized cues and to figure out what those cues mean. Am I hungry? Am I thirsty? Am I tired? Am I sick? Am I lonely? Am I scared? What is it I am? What would make it better? And then how do I do what I need to do so I get what I need? And so now, does the repetitive behavior make a little more sense? Because I'm stuck. I don't know what it is, and I don't know how to fix it, and I don't know how to make this different. So I think when we combine the sensory strip changes that we frequently see with many dementias with the wiring into the language center, but then the retained wiring over on this side, that should give us some power to choose something different. So offering me options, but the options are immediate and the options are guided, versus asking me to give you options from my repertoire if I don't have them. So showing me tired versus showing me the bed might be a way to shift from using concepts to using a much more immediate concept. But if you show me the bed, then I probably better already have my PJs on, because I doubt that I'm going to pause and let's go through the routine of PJs if in that moment my brain was tired and it did recognize tired in bed. Then stopping to switch into PJs is simply not going to happen. So now my helper has to take the PJs out of the bedroom and bring them to the living room, and then take me to a place where I will engage with the PJs. And you show me PJs, and it means sleep. But if you show me the bed and the PJs, I just want to go to the bed. Why would I do the PJs? Because I'm going to get the thing my brain wants. But then, of course, then we have the very first step of, okay, well, how do you get me up? Well, getting me up has nothing to do with going to bed. So getting me up might have to do with using something that makes me want to move. Well, what could that be? Because I'm already sitting. That's sort of less active than being active. So maybe we're going to need to use music in some fashion or rhythm. Do, 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 do. Do, 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 do. I may have to bring my energy up, use rhythm to get your energy up, and I want to use whatever music is your best, most energizing music for a little bit, but I want to be careful. I don't want to turn the radio up too high, because then I got to bring it back down, because yeah, I can get you hooked, I can get you energized, but can I control the energy? And this is that moment where you have to realize a little bit of energy can go a long way. So we want to learn that art of turning up the radio just a little bit, not too high, stabilizing it, and then starting to bring it back down. I'm going to pause because we are just about out of time here, and I want to leave time for more questions. And here's the first question I want to ask is, among caregivers, who has learned all these skill sets that I'm just talking about, and who could help people learn these skill sets so that what we're dealing with is a more robust and flexible workforce compared to the workforce that we've been asking people to be, which is consistent and static and stable? how are we going to get this to shift? Because all of a sudden we're asking for whole new sets of skills in order for people to be able to live well and live life with a developmental disability and with dementia, knowing full well that the direction of travel has been defined and the destination we get. So the question is, how are we going to live well till we can't live anymore? So I'll open it up to the group and see if you have any thoughts about how can we begin this process of starting to help people become more aware, more knowledgeable, and more skillful at making this transition in the world of developmental disabilities when dementia is now front and center. So I'm open for conversation here. Anybody
So
have?
Betty is typed in. She, I don't know if she can talk or not, but she said trainings like this can be shared with family members and coworkers and plan to work together. So kind of getting that awareness level out there first, just getting people to see what we're talking about. And then Debbie also says more awareness.
Yeah. That's been my experience, is that people are totally not aware. I did a series of workshops recently for people who care for people with developmental disabilities. That's what they do. And that they were not even aware that what they were possibly or probably seeing was a dementing illness was pretty concerning, especially when I was hearing people describe clear signals and symptoms of significant Lewy body involvement, not even a question mark. Severe and significant symptoms of frontal variant, frontal temporal dementia, or significant symptoms of a temporal lobe primary progressive aphasia, of loss of language that was pretty rapid and pretty significant. And yet people had no idea that they were like, you're describing Paul, you're describing Harry. That's exactly what's happening. Oh my Lord, you won't believe the number of team meetings. And it's like, ay, ay, ay. Because the sad part was everybody was trying really hard, but this was group after group. And, you know, people, it's not that people weren't committed, just didn't know what they were looking at. So awareness. Okay, that's great. Any more thoughts or ideas about how to make that awareness more available to folks?
Erin says, I'm a professional caregiver and have been training all the employee care partners. She's one of our trainers for PAC. So in addition, she opens it up to families, which is a group that often gets missed when we talk about training and facilities. That's a big group that's also missed.
Let me add that when we talk about Down or Down syndrome, whichever one you like, one of the realities is most mothers who have children who have Down, their age when they had the child is in the more mature group. So above age 40 or above is a normal age range for people who have Down, for mother. So if the child is now 45 and the mom was 40, how old is mom? Mandy, you want to give me your estimate? Let's see, you're a math whiz.
70s, 80s, depending.
85, let's say, in the 85 age range, which is the highest risk for developing your own Alzheimer's. How stressful has it been to be an advocate for my kid my whole life? And now my partner left me a long time ago, which is pretty much over 70% of people who have families don't always stay together when developmental disabilities hits. It's a tough combo for families to stay united. We also have the older siblings frequently trying to help, and it is not uncommon for them to have a parent who is starting with the early signs and signals of a dementing illness that everybody missed, in addition to having now a younger sibling who may be showing signals and signs. So families, one of the things they might get as a bad rap, when you might actually be looking at not only does this younger version of a person who's in their 50s or 60s have an issue, we also have a family member who's in their 80s who is having an issue that nobody noticed because they've always been a challenge to work with. And what we missed is, yeah, that's true, but now we're seeing some new levels of anxiety or depression or distress. And what we missed is who's screening them and who's monitoring them and who's keeping track of them. So, yeah. So that agitation, that distress, family members can use habits and routines, and it worked before, but now it's not working, and that becomes more distressing.
The other piece that somebody mentioned is there's two kind of components. That there's that getting family members to realize that yes, their feelings are important, but it's still about this person. And then how we've normally, as you mentioned earlier, how we've often controlled those behaviors in the past is by adding in rigidity and structure, and so that then creates a really heightened level of agitation and frustration, and then the emotions boil over quickly.
Well, the other place that we haven't really talked too much about is Corey. What is going on at work? Because she's I've never seen her like this. What are you guys doing at work? Because she used to love going to work. Now I can hardly get her in the car to get to work. What is going on with you people? What are you doing? And so we start fighting among ourselves and blaming each other for what we didn't notice isn't any one of us. It's the change in one of us. So I would have to have further workshops where people came up with what's your situation, and let's work them through a little bit. Let's talk about them, because I think developmental disability is an area where we haven't had much conversation. And I noticed somebody saying lifelong mental health issues, a whole nother population that, oh, let's take the cover off this and let's go, oh, we got a problem, because more psychiatric help isn't really what's going to make a difference. We now have mental health long-term, but now on top of that, we have some dementia kicking up and becoming challenging. So thank you for everyone who's here. I hope it was something that you could use to help raise awareness and make a difference. So thanks, everyone.
So, wow, guys, I hope that you've enjoyed this section. I know that this whole discussion about dementia and developmental disabilities has just raised a lot of questions for me, and I wonder if that's done the same thing for you. So part of what came out in this last section about, well, what should we do next, right? And I think part of what we need to do next is that teams need to start talking more. We need to change from, we need to be talking to each other and finding out, hey, are you seeing things that maybe don't make sense? Maybe, oh, remember that timeout that we talked about at the beginning? Maybe we need to do something around that, right? Piece that I heard Teepa say is the fact that when we're talking with the person with BD, instead of asking questions of the person that maybe they can't answer or they're having trouble answering, maybe what we should be doing is starting to offer immediate options, this or that, and offering guided assistance, which I know is really different for us who have been care partners for people with developmental disabilities in the past, where we've wanted them to be independent and be able to answer their own questions. But this isn't just the issue with the developmental disabilities anymore, right? We need to realize that behaviors might not be behaviors at all, but actually signs of brain change, right? So the last piece about this is, well, now that you've watched this and I've watched this, and well, how are we going to get more people to awareness and knowledge? Wow, it is a big question, right? So I'm going to leave you with this, the fact that we still have this question. We don't have the answers, and I don't know that you have all the answers, but will you let us know what you think about this, and how can we keep communication open between the dementia community and the developmental disabilities community? Are there ways that we can work together to bring awareness and knowledge and education to these groups? We're open for suggestions, right? I also wanted to mention that there are some other resources that they can be found in some of the Teepa clips or in the online videos. I'm thinking especially around the ones that talk about the various dementias. So we have webinars and we have clips around Alzheimer's disease, vascular dementia, Lewy body, and frontotemporal lobe. Maybe if we start offering that kind of education to folks in a package with this kind of discussion, we can get people to a little bit more awareness. And lastly, I wanted to mention 2 resources that I know that are still good. We had some resources from this original video that are a bit old, and but 2 that I wanted to mention is the ARC, which is the arc.org is the website, where they're all devoted to developmental disabilities and education around developmental disabilities. So I thought, if you're interested in this topic and you want to know more, check out the ARC. And then there's also this other dementia task group on Facebook, and I've put the link right here, facebook.com/NTG Dementia. Take a look, see if you want to get involved. So I hope you enjoyed this clip in this chapter, these 4 chapters on dementia and developmental disabilities, and maybe we'll get back together again for some more. Thanks so much.